Yeah, I mean, there's a lot of creative ways to get data. A lot of people are using like claims data from insurance claims. They're sort of getting a big data. You can find a lot of patients. So looking at and now with coding, diagnosis codes, you look at pulmonary hypertension as a code for an insurance claim. And in the U.S. obviously there's a lot of different insurance companies. It's different in other countries, but you can really then look at, for instance, what testing has been done, what drugs are being used, get patterns of use. You often can't get very granular, as we say. You're getting a higher view, but you can look at it in a lot of patients.
Yeah, we saw it at our session today that we were presenting the Griffin data from the VA. So the VA is an enormous database, and patients who attend the VA have pulmonary hypertension. Some of them, and you can gather. So there are those, but also national registries have been important, not just registries from drug trials and seeing how patients are using them, but for national registries. And we learn a lot from them. We've learned a lot in the last few years that PAH as a disease seems to be sort of shifting, or at least what we're seeing older patients that we wouldn't have seen previously. So we have to reset where to look for the disease. We used to say, this is a disease that in the old days, I suppose, idiopathic pulmonary arterial hypertension, formerly primary pulmonary hypertension, was a disease of young women in the mid-30s. So you knew where to look in the sense of a young woman arrived in breathless. You thought, well, this is unusual. Maybe it's primary pulmonary hypertension. Maybe it's idiopathic pulmonary arterial hypertension. Now we've learned from these registries is that's not necessarily always the case. You may have a 55-year-old person who comes in and says, I'm breathless, and you're thinking, well, you're not doing any exercise, that's why you're breathless. But in fact, normal pulmonary function, normal chest X-ray, ECG, they need to go for an echo. And the echo is the number one screening tool to see if the person has problems with the right ventricle. So again, in primary care, someone comes in and it just doesn't fit. Think of an echo as a really valuable screening tool.
Yeah, the last thing I'd say about registries is, especially some of all the registries, Europe and elsewhere, allowed us to start to look at things like risk stratification. And so one of the big sort of mantras now in pulmonary hypertension is determining what risk category a patient's in based on composite parameters and coming up with these scores where you can actually profile somebody when you see a patient. And when you treat a patient with these therapies, determine are they into what we call the low risk category, meaning they'll have a good prognosis, and we can quantify that. So these registries have really allowed us both to develop some of these scores and then to validate them to show that they actually are predictive. And that's really how we're treating. And we have some data from the Griffin subgroup to really look at the ability of the agent to lower risk and put people into a low risk category. That's really important in our treatment.